Hello and welcome to today's webinar, How to Partner with Your Local Housing Authority, Challenges and Benefits for Community Health Center. My name is Melissa Da Silva and I will be acting as host and moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. And now I would like to introduce you to our presenter for today's webinar, How to Partner with Your Local Housing Authority, Mr. Alex Lehr O'Connell. Alex is the Director of Technical Assistance and Consultation Services for Community Health Partners for Sustainability. He has worked for years securing local, state, and federal government supports as well as foundation funding for the organization and for health centers across the country. Alex also currently serves as Principal Investigator for the National Cooperative Agreement with HRSA through Community Health Partners, and through that provides technical assistance to health professionals, health administrators, and development staff across the nation to make their health centers sustainable providers of high-quality services for vulnerable public housing communities. And with that, I turn the mic over to Mr. Alex Lehr O'Connell for the remainder of this presentation. Alex?
Thank you, Melissa, and I want to say thank you to the National Healthcare for the Homeless Council. This is really a great opportunity, and we're so excited to be working with them. As mentioned, my name is Alex Lehr O'Connell. I'm with Community Health Partners for Sustainability, which, as Melissa mentioned, holds a national cooperative agreement with HRSA, Bureau of Primary Health Care, the Office of Special Populations Health. As I know, many of you are grantees of the Healthcare for the Homeless HRSA program. Similarly, today what we'll be talking about is somewhat couched in Section 330I funding. We'll get into that later, which is funding set aside by HRSA to support health centers that serve public housing. But with that said, much of what I'll be presenting today can apply to all kinds of health centers, whether you're HRSA supported or not. And we certainly, through Community Health Partners for Sustainability, work with health centers of all shapes and sizes. So I'd like to, with that in mind, ask that you keep an open mind and think about how this information might affect your health center. And thank you to all of you for joining us today. I hope that each of you can get something useful out of this. And I definitely welcome your questions towards the end. What I hope we can accomplish today is that you'll be able to identify some access barriers that public housing residents share with homeless individuals. The idea there is if many of you are already serving homeless individuals in your health centers, and the challenges that those individuals face are not so different from the challenges common among residents living in public housing. And similarly, the model of care delivery that works well for public housing residents shares much in common with successful models of care delivery for the homeless. I hope you'll be able to identify at least one benefit to partnering with a housing authority. We'll also talk about some of the challenges to such a partnership. And of course, hope that you'll better understand HRSA's public housing primary care program should you choose to pursue that funding in the future. So, of course, why should we partner? Partnering is hard work, and it's not worth doing unless there's a good reason. As safety net providers of healthcare, you are the access point available. And if there are low-income people living in your community, there's a good chance they're showing up at your door. Likewise, if you have homeless patients who successfully access housing, maybe they choose to stay on at your center because they have that great relationship with your clinical and outreach staff. So whether, this is all to say whether you're officially funded by, the Public Housing Primary Care Program, and whether you know it or not, there's a decent chance some, if not a large number, of public housing residents are coming to your health center already. So again, why partner? Well, if you look to the left, you can see an idea of what happens without partnership. You'll have multiple organizations, and they may have an idea of what they want to accomplish. In this case, if you were to ask a low-income community, certainly if you were to ask a public housing community, what's most important, what do they need the most? chances are the first thing they're going to say is, I need a home. I need somewhere safe to stay. And obviously you encounter that every day working with homeless populations. Maybe the second thing they're going to say is, I want a good job. I want a decent job so I can pay the bills and keep my home. Most often, it's not going to be until third that they're going to say, I need health care. But with that in mind, of course, we know if what we want to do to alleviate the effects of poverty and to promote healthy communities is provide people with everything they need, that includes decent housing, a decent job, and decent access to timely, appropriate health care. That's one grand idea. The only way we're going to get there is by seeing that all of us share that. You have that mission. The Housing Authority has that mission. Housing providers in the community have that mission. It's the larger objective of giving the community everything they need to lead healthy, productive lives. Only together, by sharing our various strengths, can we achieve that social change. Again, why partner? The idea we want to align a joint response, coordinate the activities the Housing Authority is doing, the housing organizations are doing, workforce development organizations, and of course, healthcare. Only if we align all of those can we address the intertwined issues of housing insecurity, poverty, and lack of access to healthcare. More practically, as a health center, no margin, no mission, you've all heard it. The public housing community should be an attractive source of patients, especially to an FQHC, Section 330 funded health center. By virtue of their low-income status, virtually all will be Medicaid eligible, and that equals good revenue for your health center. Of course, in addition, by partnering with a housing authority, the health center can gain access to funding opportunities that are traditionally not open simply to health centers. Likewise, HUD applications from a housing authority to HUD can rise above the cloud, can sort of really appear innovative if they show true partnership with healthcare. Not every housing authority makes access to healthcare part of its daily activities, and it really can be seen as innovative. Those funding opportunities, for example, healthy homes programs, and I apologize if you're hearing some sirens. I'm located in downtown Philadelphia, right on Broad Street, and of course we sometimes get siren noise. And I think it's now passed. So back to funding opportunities, which of course is critically important for everyone. Out right now is their Notice of Funding Opportunity, the NOFA for HUD. It contains healthy homes funding. And this is the idea that you go into a home, assess it for a whole range of environmental health hazards, everything from lead to asthma triggers, to fire and safety hazards, to fall hazards. And what we found in a number of communities is that the local health department may take on the remediation role of actually fixing those homes, and the local housing authority may take on the role of fixing the public housing homes. But often, it's the outreach workers in the community at a social service or health organization or at an FQHC that can meet the community head on, meet them where they're at, gain entry to those homes, because it's not a regulatory official, it's not someone in a city government uniform showing up trying to do a home visit. It's a public health nurse, it's an outreach worker hired from the community, that kind of thing. So those kind of collaborations really can make for effective projects that can meet with good response from HUD reviewers. And then finally, and most immediately, housing authorities have resources, the number one being space, and I'll explain that in a moment, but also their human resources in terms of outreach staff and staff that they have already interacting with those potential patients. So the Public Housing Primary Care Program, this is the most sustainable way to provide care to residents of public housing. Similarly to the Healthcare for the Homeless program, it's authorized by Section 330, specifically subsection I. It's overseen by the Bureau of Primary Health Care, Office of Special Populations Health. It is the smallest of the cohort of special populations. Its set-aside funding is about 1.5% of the total health center allocation. That resulted in in 2010, they served about 172,000 patients through about 50 reporting grantees. It's expanded somewhat through the most recent New Access Point awards for fiscal year 2011. And similarly to health centers serving the homeless, public housing health centers can also, in certain cases, access waivers of governance of certain governance requirements. So examples and these are two examples from here in Philadelphia that both partner with our local housing authority, the Philadelphia Housing Authority. The first, I'll actually take the second one first. Resources for Human Development. The Family Practice and Counseling Network was one of the first grantees of the public housing primary care program, and they came to an agreement with the Philadelphia Housing Authority that the Housing Authority had some extra units available within a neighborhood public housing development. They renovated those units, leased them out to the health center for $1 a year, and the health center therefore was able to open up. It opened up small, just with a couple exam rooms and a single provider and a single medical assistant. And from there, it's grown to now serve thousands of patients a year in multiple sites. And Public Health Management Corporation operates 2, and actually now 3, I should correct myself, public housing primary care sites, again, in partnership with the Housing Authority. So the FQHCs, just like all FQHCs, they're going to provide comprehensive health care, health promotion services, on-site referrals for specialty care, and they're going to augment Housing Authority events like community health fairs, that kind of thing. The Housing Authority, in return, in many cases, provides the space, so in the form of spare units that they have to host the clinic. And then on an ongoing basis, they make sure all new residents who come in are aware that services are available, know the hours of the center, know the languages that are available on site, that kind of thing. Help distribute marketing materials. Often they'll have like a monthly newsletter so they can include your materials in there. And of course they host community events that they welcome the health center into to give, blood pressure screenings, health education, that kind of thing, all of which is good marketing to that community. One thing that I should mention, it is an inherent requirement to the public housing primary care program is that you are located in an area highly accessible to a public housing community. And this is a situation with a lot of confusion, and we'll talk a little bit more about it later. So in a traditional public housing model, maybe a building built in the 50s or the 60s, it would be a large high-rise or an entire block of low-rise homes, a traditional public housing development. And under that model, usually the health center would be located physically in the building or physically on the block. And that's how most of these began. However, as we'll discuss later, that housing model is beginning to go the way of the dodo. There's a few cities where it persists, but in most areas, they've switched over to different models, whether it be mixed income communities, scattered sites, increased reliance on other models. And so health centers have had to adapt because the need for access is still there. So now, increasingly, public housing health centers may not be physically located in the building because there may be no building. Even in those cases, however, they have to demonstrate very clearly how they are very highly accessible, so they have to be nearby to some critical mass of public housing units, and show how actively they're going to make sure, in partnership with their housing authority, every resident, whether they live right next door or a few blocks away, know the health center exists, knows what services are available, know that there's a turn no one away policy, a sliding fee scale, all that kind of thing. So 3 recent trends in public housing, and then we'll talk about how they affect healthcare delivery. Obviously, greater demand, and as organizations that work, to alleviate homelessness, I don't have to tell you that there's clearly more demand for affordable, safe housing than the public housing system is able to meet. There have been new approaches in housing, specifically decentralization. I just talked about, the high-rise model is increasingly rare. and of course recent expanded eligibility for housing services. And we'll talk a little bit about that. And finally, how that's triggered some new approaches in healthcare. So greater demand, and I'll go through these fairly quickly because I know most of you this will be preaching to the choir. But the most recent data I had at my fingertips in 2007, close to half of all people renting spent over 30% of their income on housing. 30% of your income on housing is sort of a benchmark that says your housing is insecure because you're spending too much of your money on it. In an ideal world, we would all spend closer to 20-25% of our income on housing. And of course, for people who are low income, in the bottom 25% of the income brackets, half of them spent over half of their income on housing. So as you can see, if you're spending half of your income on housing, you don't have a whole lot left over for accessing health care. And if you were to lose your job or even have a few barriers, if you have to take a few unpaid leave days, your ability to make rent really becomes endangered. Finally, in the bottom 10th of the income distribution, 70% are spending more than half of their income on housing. As a result, since 1996, there's been no change in the average waiting time. And this is nationwide. Obviously, community to community, waiting times can vary. But overall, the waiting time has remained about a year and a half, 19 months, despite an increase of 250,000 more public housing units. And in some areas, for example, here in Philadelphia, the waiting times often exceed 10 years. Again, that I spoke about those 250,000 new units. This slide will show you that basically all of that growth has come through the voucher program. This is traditionally called Section 8. And here, the important thing to note is that for the sake of a housing agency or a housing provider, they're not going to greatly differentiate in terms of routing people into public housing versus routing people into voucher programs, because the important thing is that person now has a safe, affordable place to live. However, from the perspective of the public housing primary care program, public housing is legislatively defined as units owned, operated, or improved by a housing authority. Voucher programs are privately owned by private renters, and as a result, in most cases, voucher units don't count as public housing. Now, just to pause a second. If you are a public housing primary care health center funded by HRSA, and someone shows up who lives in a voucher property, of course you serve them because you're an FQHC. You serve everyone no matter where they live. And from a housing authority perspective, they want to make sure everyone that they interact with has access to care. It's not their problem that technically the definition doesn't cover their voucher, the properties that are, voucher properties. So HRSA certainly has some degree of understanding. I think if we were to deny access to the voucher property tenants, that would be a massive mistake. Ultimately, think of it from the perspective of a tenant. You've been waiting 10 years on a waiting list for an affordable home, and all of a sudden, the housing authority offers you a spot in a voucher property. You're going to say yes. And it would be a tremendous, tremendous problem if saying yes to that property fundamentally denied you access to health care. So this is all to say this requires a certain degree of education at every level about the difference between true public housing and voucher from the legislative standpoint, and how health centers are going to fundamentally not use that to create any kind of barriers. What I will say, to get funded, in the new access, if you're writing a new access point proposal, on Form 4, Community Characteristics, and I apologize for those of you who aren't familiar with the new access point application, but regardless, there's a spot there to note how many public housing residents are there in your service area. You can't count residents of voucher properties in that number. You can certainly go on in your application to describe, we have 10,000 residents of public housing and another 8,000 that live in voucher properties, and we're going to make sure all of them know about services available. But in terms of this, taking a census of how many public housing residents are there in your service area for that form, you have to eliminate voucher properties. Of course, new approaches in housing. The biggest one is Hope 6, dates back to the early 90s. The idea here is to change the physical shape of public housing. We don't want to rely on high-rise multi-unit developments anymore. Instead, we're going to rely on lower density approaches and scattered sites, mixed income communities. The idea that you won't be creating isolated pockets with very few resources. Instead, you're going to bring a whole community up. Meanwhile, you want to not just provide housing, but provide comprehensive services. So partner is the housing organization partnering to ensure that people have the training they need to access decent employment, that they have the access to health care they need, all that kind of thing. As a result, that has increased reliance on Section 8 and other voucher programs. Like I said, that's where all the growth in the public housing world has come from, with 250,000 more units. And here, just so that it's written down in the slides, for those of you who choose to download them, is the definition dating all the way back to 1937, the Public Housing Act, that says that Section 8 only programs, voucher only programs, are not defined as public housing. They're rather defined as assisted housing. I will say, if there is a scattered site, a voucher property, that kind of thing, it doesn't. If there is a voucher property that is improved with funds from the housing authority, so maybe a private renter owns it, but the housing authority will pays for the renovations or the maintenance on that site, then it can become eligible as public housing in terms of the eligibility for your census within the public housing primary care program. The result of that has been decentralization. We don't have one giant high-rise anymore. Now we have a mixed community, perhaps spread over several miles. Well, that means we have increased economic capital in the community, and increased economic capital can have tremendous results. However, it of course can mean gentrification and otherwise displacing existing residents, and that makes outreach and engaging that community much more difficult. I mean, residents who have been patients of a public housing health center for a decade may all of a sudden find themselves living 5 miles away, and we need to make sure that they can continue to come back to the health center. Likewise, finding new residents of the health center can be very difficult because, again, you're not leafleting a single block or a single building. Now if you were to use leaflets, you'd be leafleting an entire section of your city, an entire area of your community. So it just requires a slightly different approach. Finally, new eligibility, and this is the HARF Act, fairly recent, and in fact in the past month, HUD released its follow-up new definition of homelessness. You guys as homeless providers probably know more about this than I do, so I wouldn't spend a lot of time on it, but it is to say HUD has an expanded and I would say greatly enlightened definition of homelessness that includes people whose housing is insecure. You no longer have to be on the street or in a shelter to access certain housing-related supports. However, HRSA's definition has not caught up yet. So that is to say, in interacting with a homeless serving organization or with a housing authority, they may view certain clients as, all right, these are new people we can help. And your health center has to be prepared to work with them and meet them where they're at and not say, oh, I'm sorry, that person doesn't qualify yet because of X, Y, and Z. We have to sort of come up with a shared definition. And I would say this expanded definition is one that health centers should absolutely embrace, and I think most already have. Again, as I mentioned, as a result, many health centers are no longer physically located inside public housing. And you would have heard, you hear people saying that the rule was you must be located in or adjacent to public housing. Well, again, if it's no longer a single building, that term in or adjacent becomes irrelevant. Now the key is nearby and accessible. And accessible not just physically, but in terms of knowing that the health center exists and knowing that you can access it and knowing how. However, one thing that has not changed at all is you have to have an ironclad collaboration with the housing authority. And we'll talk a little bit about how to develop that. The number one thing is you have to start early. Waiting for a new access point call for proposals to come out and then reaching out, they're going to see right through that in the same way you would if someone else came to you. And if they're people partner with people they know. So federal expansions, and this of course somewhat assumes that the promises made in the Affordable Care Act will be followed through on, and we've seen some of them followed through on, but of course with the funding realities right now and the economy being what it is, there's some question how much of this will happen, but certainly some degree is going to happen. So again, this slide I probably don't have to talk to you much about, but Health and Human Services is obviously expanding through the recent new access points, and we certainly hope that there will be another call for new access points in the future, though, I wouldn't hold my breath. Capital improvements, those proposals are pending right now. Some service expansion funding, we would love to, of course, see that come around again. And workforce development through investment in the National Health Service Corps and HRSA's Bureau of Health Professions. These are just things that are going on. At HUD, things that are going on, they're encouraging that health centers to partner with housing authorities and encouraging housing authorities to partner with health centers. Likewise, they're encouraging housing authorities to develop policies that will improve health. Many housing authorities are implementing smoke-free policies for their residents. That's one example. Many are trying to develop safe places to exercise in the community. That kind of thing. And of course, through HUD's grant programs is one real way to develop those partnerships. Finally, Department of Labor. If the health care system expands so much, we're going to need we're going to need a larger healthcare workforce. And that's not just doctors and nurse practitioners and physician assistants and other primary care providers. It's also social workers, clinical social workers, psychologists, and other behavioral health staff. Here, I know from speaking to some of you, within a healthcare for the homeless setting, integrated behavioral health isn't a best practice, it's a necessity. And I would say the same thing more or less goes for public housing communities. Integrated behavioral health, what began as a good idea has become more or less, you have to have it. And that means having these staff on site. Of course, administrative support staff, medical assistants, receptionists, billers, all that kind of thing. And finally, outreach staff, whether you call them promotoras, patient navigators, health educators, pick your buzzword, what they do is outreach and education. So specifically, HHS and HUD, how are they collaborating? Well, they have this shared vision. Back to that why partner slide, the larger objective they want to work on is to develop safe, healthy, productive communities. And I apologize for all the words on this slide, but essentially if the problem is that public housing residents can't get health care, that means that they're not very healthy. People who are not very healthy have trouble keeping steady jobs. People who have trouble keeping steady jobs lose their public housing. Now they wind up at your health center homeless. The strategy, let's make sure residents are familiar with the healthcare sites where they can get care. So in some cases, that's going to be at a public housing primary care location. In many cases, that's going to be at some other type of health center, including a homeless health center. And of course, to work together to develop new access points, new sites, satellites for public housing communities that currently don't have a good access point. the outcome we think is that, if a resident has access to care and is healthier, they'll be better able to hold a job, better able to pay their rent on time, and be more compliant with other public housing requirements. Specifically, where does this sit? And I include this so that when you go to meet with your housing authority or when you go to meet with your regional HUD office, you can point exactly to this. So within HUD's Secretary's strategic plan, goal number 3, we want housing to be a platform to increase quality of life. You can't increase quality of life without providing access to health care. So specifically, goal 3B, we want to improve health outcomes. And they don't want to do this by getting into the healthcare delivery business. That would be a tremendous failure. So if you look at strategy 3, provide physical space, and hold on, I'm going to try and highlight it. Right here, strategy 3, provide physical space to co-locate healthcare and wellness services within housing, on-site health clinics. That is the classic model of the public housing primary care program. That said, there's absolutely no reason it has to be a public housing primary care grantee to do that partnership. And a homeless grantee or other type of health center with an interest in and serving that population and a care delivery model that's going to work is a perfect partner there. So you want to make the case to your housing authority. And here I'll say a big barrier. Housing authorities are large organizations, and like any large organization, they can, I should say some housing authorities are large organizations. So if it's a large organization, you're in a major city, and they have a large, well-developed housing authority, getting any train that big to make a course change, that's tough. And so I would say one thing that's definitely clear, housing authorities vary wildly in the degree to which they take health into account. Sometimes it's simply because it's the way they've always done things. Many times it's because they're so busy and so short-funded just to provide the basic services that they have to, access to housing, making sure that the regulations are met, that rent is paid on time, that kind of thing. They may simply not have time or energy to take anything else on. That's a shame, but it's the truth. So some housing authorities will be more or less receptive to partnership, but even when they're unreceptive, you should be able to find at some level and someone willing to listen with an open mind. And so some of those people, obviously, and I put this first, not last, the residents. Most housing authorities maintain tenant councils that meet regularly, almost like a community board of a health center. In fact, in many cases, the tenant council becomes the community board once a health center is formed. And, so getting in there, making sure you want to hear from residents that they struggle to access health care. And they may not say, we want comprehensive primary care. They may begin by saying, we need a ride to dialysis. All right, let's meet them where they're at, find out how we can maybe help make that work. If the housing authority is hearing it from their tenant councils, that's a much better messenger than a doctor, a nurse, a grant writer could be. Housing authority staff, obviously the executive leadership, but getting to those people can be tough. And again, they may be somewhat tunnel visioned on delivering their core services. I mean, especially in this economy where everyone's funding is getting cut, they may be so focused on just how do I keep my core services going with less money. I don't have time to do this. So in that case, getting down, drop down a level. The development staff, you may have a grant writer at the housing authority who is thinking of applying to some HUD grant, and they want a way to create an interesting project that's going to be more effective, that's going to better position them for funding. That's a good person to know. Outreach staff. Obviously, the housing authority has outreach staff going out into the community. That's a whole other group of messengers that you can engage. Find out from them, what do they hear people needing? What do they see people needing? And of course, site managers, the person who maintains the building, the person who maintains the properties. That's going to be your best friend, because If a site manager is having a problem, then the housing authority is having a problem. And if you can help the site manager, if the site manager believes in you and wants you on site, then you can help make the housing authority make that happen. Finally, of course, elected officials, and that can never be underestimated in any situation. So in making that case, we want to talk about the return on investment. And here just whether you're this applies whether you're making your case to a housing authority, to a potential funder, to that elected official especially, is that we know that access to primary care and health promotion will make those residents less likely to give birth to low-risk, they're more likely to give birth to low-risk, healthy weight babies. We know it. And these are just the benefits of health promotion and primary prevention. They'll access immunizations and other preventive services, screenings. They'll be more able to manage their asthma and other chronic diseases. This is going to reduce their reliance on the ER and reduce their likelihood of being hospitalized. Of course, that means they're healthier in general. Is this an oversimplification? Yes. But when you're meeting with an elected official, you bring in some data to back it up. Those healthier residents are more able to access and keep decent jobs, and including through the health center itself. Let's not forget, what does the community want? Often before it wants health care, it wants a decent job. And as health centers, you are employers. You're, having an outreach staff, a patient navigator, someone like that, hired from the public housing community, that's invaluable. I mean, they are the best peer mentors you'll ever have, and they solve myriad problems for health centers in terms of gaining trust, understanding the community, and of course, helping get people from the community into decent job tracks, that will route them towards various health careers, whether it be as a nurse, as a medical assistant, as an information technology person, as a biller. All of these are what the community needs. Here I bold pay rent on time and meet other public housing regulations. The bottom line is housing authorities their lifeblood is their rent roll. All of their residents are required to pay 30% of their income in rent. And it is the housing authority's greatest task to make sure that their residents are able to pay that rent on time. If they're healthy, they're going to be far more able to do that. Longer term things, we know that children who have well managed asthma are going to be able to avoid school absences, graduate on time. Obviously, that has long-term economic and social benefits for the community and the individual. We think healthier residents will maintain safer households. If someone is regularly being counseled on tobacco cessation, they're less likely to smoke in their home. We also know that access to health care can reduce domestic violence. Ultimately, they achieve a higher quality of life. Now, the money. And here, we're going to take a slight digression into the need for job training. Am I expecting a bunch of health centers to become job training organizations? Absolutely not. This is, again, backing up to that early slide on why to partner. There's you, the healthcare provider, there's a housing authority, the housing provider. A third resource that community is going to need is job training and workforce development. At the same time, your expanding health center is also going to need good, well-trained new entry-level employees. And here we just see that someone with an associate's degree, such as an entry-level nurse, an entry-level IT professional, something like that, is earning on average double, or close to double, what someone who doesn't have a high school diploma is. What's the result of that increase in income? Well, they go from requiring, being a net drain on the overall, government revenues, and here I'm speaking directly to an elected official you might be meeting with, to contributing quite a bit in terms of taxes. This is what happens when you empower communities. So finally, as health centers expand to serve more public housing residents, and this is a repeat, we know their access to needed services is going to increase. As that access increases, we know their health outcomes are going to improve because all health centers are measuring the quality of what they're doing and implementing best practices. Ultimately, those residents are going to become more self-sufficient. They're going to find employment and quality careers through the health center or another venue. And ultimately, back to that initial idea, we can better achieve that larger objective, which is empowering the community, which is having safer, more productive communities throughout the entire nation. So quickly, a little bit, and then we'll get to some questions. Who is Community Health Partners for Sustainability? Again, we're here to work with the National Healthcare for the Homeless Council and with each of you as needed. We do some webinars. We have a website that I'll get to in a second that sources some materials for you. We can certainly make site visits available. We help with some document reviews. So like if you're working on a pitch, for a concept paper maybe for your housing authority, we could certainly help out with that. We help communities develop needs assessments, complete their planning grants, all that kind of stuff. The main thing we do is we work one-to-one with people, and we're going to begin with a conversation. Again, all of this is free because we're supported so generously by HRSA's Office of Special Populations. When in doubt, call me. And there's my information for our website. It is www.chpfs.org. That covers my presentation, and I will turn it over to Melissa for some questions. Again, thank you all so much for taking the time. I know you're all very busy, and I hope that you've each found something to take home out of this.
Thank you, Alex. That was a terrific presentation. I'm happy to be able to add this bit of information on public housing primary care to our audience, I think primarily healthcare for the homeless grantees. So we have two questions only. So Daryl is interested in knowing, so do you know, Alex, how many units have been condemned nationwide? And the time period I think he's referencing is on slide 13. 1996 to 2008.
Thanks. And Daryl, that's a really good question and something I should have included. I actually don't know exactly. We can see if you look at slide 13, in terms of public housing, the number has dropped. However, this number dropping includes the construction of new public housing sites. So there's definitely been turnover. I don't know off the top of my head. What I can do, especially if you shoot me an email after the fact, I'm happy to track down that number and send it to you.
Thank you, Alex. Does your agency have a listing of resources or offer any trainings to community members on how to become a patient navigator, as you stress the importance of that role in partnerships? Alex?
We don't currently offer that training, a training on patient navigation and that kind of thing, training for communities. We don't currently offer that directly, but what we can do is link you to some groups that might, whether it be a national organization or an organization closer to you. I'd encourage you to shoot me an email with that, and I'll see what I can dig up that maybe will work for you.
Thank you again, everyone, for joining us for this terrific webinar presentation. Our presenter, thank you, Alex Lehr O'Connell of the Community Health Partners for Sustainability. I would like to turn your attention to some other resources on the National Healthcare for the Homeless Council website. So thank you again, Alex Lehr O'Connell, for this terrific presentation. Thank you, participants, for attending our webinar on partnering with local housing authority. Please complete our survey upon exiting. Join us for one of our upcoming events. Check out our website for upcoming webinars, and wishes for a terrific day. Thank you all.